That's terrific. May we then move on to the next item on the agenda, which is devolution, our proposed principles and decision-making criteria. I'm going to invite Ian to introduce the paper.
Thank you very much, Chair. Devolution is one potential approach to collaboration between the NHS and local government. It is consistent with the move to delegate functions to CCGs and to place-based commissioning and more integrated provision. It has the potential to unlock stronger partnership working between the NHS and local government, and our close working with Greater Manchester is a very good example of that. NHS England has a very clear set of its own statutory duties and responsibilities. And insofar as we consider entering into future devolution arrangements with other parts of the country, the board will naturally want to assure itself on a number of points. And the paper presented today sets out some proposed principles and decision criteria for how we would assess propositions coming forward from local areas. And those criteria include the clarity of the purpose of the bid, the clarity of the vision of what the different parties are seeking to achieve together, and why the bid is necessary to enable that rather than merely utilising existing extensive powers to enter into joint arrangements. We would expect robust governance arrangements, clear and effective collective leadership, a continued commitment to national standards and a track record of compliance with them, both in relation to quality and to finance, and local support for what is proposed, and strong relationships with the community and indeed with other communities with whom the devolved areas will need to have an ongoing relationship. I would also ask the board to recognise the practicalities of the amount of time it takes to move from early discussions around the principles into worked up agreements. Our experience with Greater Manchester suggests that this is likely to be in the order of 18 months. And I invite the board to consider the principles and decision-making criteria and resolve then, in the light of that, to agree that the commissioning committee of the board oversees any future decisions around entering into arrangements.
Thank you, Ian. Let me invite comments and questions from members of the board. Kieran?
To be successful, there's going to be a different model of operation. So some of that will be hard skills like population evidence, analytics, truly understand what's happening with the pathways. Some of it will be soft around the ability to collaborate as opposed to compete, which some of the geographies going for devolution have been quite good at. What are we going to do to have interventions which say, are we building the skills, both hard and soft, to make this work?
If I may, could I turn to Paul to potentially pick up on what is being done in relation to Greater Manchester, which is our current live example. So I'm the board lead for devolution more widely, and Paul has been leading the work on Greater Manchester.
I'm not sure it directly addresses your question, because I think in Manchester, to the point of the criteria, we identified a set of leaders who had a strong track record of doing collaboration and who could build on that in the ambitious plans which we've been pursuing there. So whilst we continue to give lots of support to the Manchester team in doing all of that, the starting point wasn't one where there was a massive need for development, I think, of leadership capability in the sorts of areas you're talking about, and most of the support has gone into the harder stuff that you talk about, which is perhaps not at the centre of your question. But I think that's why in a sense, we can't afford to take on devolution cases where there isn't already a strong collaborative leadership track record, which is kind of one of the principles we've got here.
So if I may then add to Paul's comment, I think your question highlights a need across the health service for us to look to nurture and develop collaborative leadership styles and models. And I think that is a theme that is picked up in Ed's review and something that we need to progress as we implement that review.
And the analytical side and population evidence and new models of commissioning?
So through a combination of different programs that we have, so not specifically in relation to devolution, we are looking to improve the basics of business intelligence for commissioners through things like the lead provider framework and the work on information for commissioners. It's vital that we get that right, and I think there's a combination of three elements to that. There's one, improving the caliber of the data sources and the timeliness of the data, and resolving some of the long-standing information governance constraints. Secondly, there's the nature of the analytical tools themselves, and then third is the skills for people to be able to make best use of those tools, because to pick up on your point of population health analytics, a lot of the best tools are intelligent query tools that are available for curious users to work out what this means for different questions they may have. And so simply constructing the tools and making them available will be inadequate in terms of achieving the effect that we want.
Moira.
A question first, Malcolm, about Principle 3. The principle of subsidiarity, ensuring decisions are made at the most appropriate level. Isn't it the lowest appropriate level, the subsidiarity? And should we not have that in there?
Yeah, I think that's a very helpful clarification, Maura.
And secondly, really, have we discussed these principles with local government? Will they land well with them, or will they be seen as a defence against devolution?
There has been, I can confirm, there have been conversations with local government.
And will it land well?
I think that we in NHS England and with CCGs are highly supportive of how do we make devolution work. And these principles are intended to achieve that goal rather than to act as a barrier to different forms of collaboration, of which MOUs between the NHS and local government is one type.
Yeah, I mean, I think this is going to take different forms in different parts of the country. More obviously, Greater Manchester is in its own category for the reasons that Paul has set out, not just because it's first off the blocks, but because a lot of the heavy lifting that would need to be done to make it successful was already a work in progress. Different parts of the country are coming up with different propositions. My board report, you saw the work that the local authorities in the West Midlands are wanting to do on mental health and work, and they're looking for us to support specifically around that agenda. So, we will play in those. But above all, I think what local government is looking for from us is a point of view, a clearly understandable, predictable point of view about the circumstances under which we will and won't engage with different models or propositions. And I think actually the devolution label sometimes obscures rather than reveals, because in the context of the 10 councils in Greater Manchester, what we're actually doing there is three separate things together. We are devolving some of the national budgets, they are aggregating some of the fragmented local budgets, and we are blending health and social care. So actually it's a devolution, an aggregation and a blending, not just a devo-mac.
Victor.
Ask a question about some of these criteria are quite difficult to measure and judge, and we haven't done it before. We haven't done this before. So I'm curious about whether and how we're going to learn as we go along. So, for instance, demonstrable track record of collaboration and engagement with patients and local communities. Are we going to be saying, well, evidence that they're engaging with NHS citizens, or that they have so there's really two questions. Are we learning as we go along, and do we have kind of sub-criteria, measures that we're using to make these judgments, because it's kind of new, it's new for us as well?
And my answer, I think, partly reflects your last comment, Victor, that this is new for us. So these are a set of high-level principles. There is not a sub-level of different clear metrics that we have that we can today, say, apply in relation to each of these areas. So there is a strong element of judgment in relation to each. That said, some of the criteria, such as current operational performance or financial performance, it is much easier to look at the existing quantitative information.
David. Malcolm, I think the importance factor in this is this is not a sort of here's our plan, agree it or don't, is that actually this is an iteration and a conversation. And because a number of these principles are things that we would want to develop with the areas concerned rather than be presented with, and a number of them, such as a clear mitigation plan, will clearly come out of the experience we've had from doing other things. So I think my sense is that we have to be quite adept at learning from the various experience, and also helping to shape some of the proposals based on the learning that we get. And Ian, therefore the question is, have we got the capability and capacity to do that, given there is significant interest?
I think your framing of the issue, David, is extremely helpful. What we don't want to do is to see this as a single episodic gate, and instead this is part of the development of the relationship between the NHS and local government more widely. My understanding is that there has and is considerable engagement between different NHS partners locally at CCG level and with area teams with local government as people have been putting together their propositions. Inevitably, given the tightness of the Treasury deadline for September, the propositions that will come in are, in some instances, will be staging posts rather than the final word. But I don't know whether, Barbara, you would want to add anything from the perspective of your regional director or director of commissioning operations colleagues on how the relationships are going with local government on these propositions.
I think we've seen a significant improvement in relationships across the board with the Better Care Fund. I think that the Better Care Fund has drawn together CCG leaders, our leaders and local government leaders kind of to work on the whole health and social care integration agenda. I think that across the country, people are building on that, and particularly where there's a strong interest in devolution, we are seeing people talking about it, and I think people seeing it as a shared initiative. As ever with all of these things, it comes down to personalities. Yeah. So you can see places whereby the leaders are absolutely committed to working together and have been before the idea of devolution, and they're the ones who can make the most rapid progress. And we do still have some areas where it would seem that personality gets in the way of progress.
And I think that's important, because to Moira's point before about are these a set of criteria that are sort of impossible to deliver, or are they a clear set of staging posts that people can see? I think we shouldn't see these as being sort of cast in stone and sort of people have to get sort of perfect on all of them. On the other hand, we absolutely need colleagues in local government to recognise that actually this is born out of our experience, and actually unless you get these things right, you're going to find it difficult. And in the words of one of my ex-bosses, very wise, he said, to those whom much is given, much is expected. And actually, therefore, we can be a facilitator and an enabler to help make this work. And I think that will require both the local government side and ourselves to have a slightly different mindset than we might have had before.
Right, I think that's been very valuable, Ian. I mean, the social geography and actually the physical geography of England is terribly varied. Great demographic differences, great leadership differences, and what we're doing here, I think, is recognising that, but not recognising it from a top-down perspective, but from trying to understand and accommodate bids for local self-determination, of which health is but one part of a broader package. And I think the board are telling you that the criteria that you've specified in the paper seem to us to be appropriate, but it will not be, as it were, a one-off determination, but a process of collaborative working across the piece, always with the objective of trying to improve and enhance the quality of the offer of the care that we offer to our patients, and joining much more significantly with local government than has been possible even so far with the Better Care Fund.
I think we've also just discovered that one of David's ex-bosses was St Luke.
So that's
My ex-boss was brilliant at plagiarism.